Hey everybody, Dr. D here with Beltline Health, bringing you the next installment of the videos explaining how the surgeries work. Just to remind you, we talked previously about why it can be frustrating to not be able to lose weight, a term called metabolic adaptation. I then talked about the sleeve and hiatal hernia repair. Now we're going to talk about the gastric bypass. This is a picture of the gastric bypass in kind of its completed form. We're going to walk through this and how making these changes to your normal anatomy can help us get the changes that we want. And so I'll start by telling you that this takes 6 small incisions to complete, whether done robotically or laparoscopically. It can take anywhere from 75 to 105 minutes to complete. The first part of the surgery is going to involve us creating a small pouch. This is described as a half teacup size or a large egg size pouch. That becomes your new stomach. A couple bites of food obviously can hit that and make you feel full. For the second part of the surgery, what we're trying to accomplish is creating something called malabsorption. In order to do that, what we're going to do is come down here and divide the intestine and reroute it up to the pouch. And I typically in the office I'll show it like this. So if this is your bowel coming across the stream completely connected, we're splitting it in one spot and reconnecting bowel to itself down here, and the top part of that bowel is being connected to the stomach. So the reason I show it that way is to prove that, hey, I didn't remove any part of my arm, so no part of intestine is cut and removed. It's just divided and rerouted so that we can impart these changes that I'm about to describe. So what happens when we do that is we achieve a couple of things. So the first thing we achieve is changing the critical mixing point. And if you've watched some of my earlier videos, I like to call this critical area indicated here with the star the mixing point. What's mixing? Well, the food you just chewed and swallow is first processed in the stomach a little bit normally, and then spit out into this first part of the small intestine where it mixes with the bile from your liver and the gallbladder, shown here, as well as not shown here, the pancreas and the digestive enzymes. And remember, it's really a chemical reaction that breaks that food down so you can absorb all of those calories from their different derived sources, proteins, lipids, and carbohydrates. So mixing is kind of important. Normally it starts here and you have about 16 to 20 feet of intestine to absorb every last drop of that. Well, by rerouting intestine, we're shifting that mixing point further on down the small bowel. So now look, food you've just chewed travels relatively unprocessed by this small pouch down a couple of feet of that intestine before it meets up with those digestive enzymes further downstream. From this point to the end of the bowel now, so-called common channel, is effectively a shortened version of the original bowel length. So because mixing needs to happen before you absorb calories, the effective length of bowel is shortened because what we're doing is decreasing the amount of small bowel that's exposed to that food. And so we're limiting how much of the calories, in this case, if you're someone who is getting excess calories and poor quality calories, we're limiting how much of those calories that you're going to be able to absorb. So without, again, removing bowel out of the abdomen, we're effectively shortening that functional part of the bowel from, I estimate, 16 to 20 feet down to about 10 to 12 feet. And that, ladies and gentlemen, is how you create malabsorption. So the gastric bypass is both restrictive and malabsorptive, which makes it different from the sleeve, which we called primarily restrictive. But I also did call the sleeve metabolic, and believe me, the gastric bypass is metabolic too. I think there's some things that we don't know yet fully about the bypass, but what we do know is that, for example, not letting food see this first area of the intestine affects different gastric hormones or different gastrointestinal or intestinal hormones from being produced and injected into the bloodstream. So we do alter hormonal signals that normally go from the bowel up to the brain to communicate and impact changes. We're changing that. So in some way or another, this does become a truly metabolic surgery. We do see that hike in metabolic rate after the weight loss surgery. And also because this area is not exposed to food, we believe that's why this is actually a superior operation for someone with diabetes. That particular feature of this surgery may be why we see improvements in insulin resistance after this surgery compared to the sleeve as well. The other thing I want to point out, this little pouch here, as opposed to that tubular sleeve-like stomach from the sleeve, is generally a lower pressure system. And so this surgery tends to be better suited for treating associated reflux. If you're overweight and you have bad heartburn, reflux problems, already on medications, we're probably going to be talking about this surgery for you. So that's how this works, so you understand how reorienting things allows us to see the results that we do. I want to briefly move on and talk about the benefits. So 60 to 80% excess weight loss at 3 years post-gastric bypass is what a lot of the books and studies say. You may be wondering, why is that the same as the sleeve if this looks so much more complicated? Sometimes I wonder the same thing. What I tell my patients is, yes, it's a wide range, and I think it varies because of factors, demographic factors. The patients getting the surgeries, obviously we have a very broadly distributed demographic of patients getting at different ages, different abilities to exercise. You know, someone who has knee pain is just going to rely on the surgery and the malabsorption, may not get in those 3 to 5 days of exercise that we recommend that goes with it. So someone who can maximize all the tools that need to go with the surgery may see more weight loss. So I think there's a wide range here, but I tend to tell patients to think about the surgery this way. I caution patients to believe that with the sleeve they'll really see the high numbers at 80% or more, with exceptions. So I tend to tell patients, if you know, with the bypass you're more likely to hit that 70 to 80% excess weight loss range than you are with the sleeve. The real benefit of the bypass to me is the durability of the weight loss. So patients with bypass do better long term in terms of maintaining their weight. We see a higher weight regain rate with the sleeve, and I think that has to do with, again, that malabsorption part. If you have the sleeve, you're relying just on that restriction and that metabolic effect, which we know lasts about a year and then it tends to go away. Well, I think the gastric bypass is a little more forgiving if you fall off the diet wagon, so to speak, because it has the malabsorption to help you maintain that weight loss. As I said before, it's better long-term diabetic. It has a better long-term diabetic remission rate than the sleeve. So if you're a longer-standing diabetic patient on insulin, for example, we may favor the bypass for that reason. And also, like I said, if you've had long-standing reflux, and we definitely don't want to take any risks of making your reflux get worse by choosing a sleeve, we may consider the bypass in that situation too. Typically a 1 to 2 night stay in the hospital, just like the sleeve as well. Finally, let's talk about potential complications. Again, anytime we cut the stomach or the small intestines, there's going to be a chance of a leak. That's a failure of that thing that we just cut on to heal, and so you could have a leak and get an infection. Stricture, just like I said, the sleeve can stricture, so can the connection point of that new pouch to the small intestine. These next two, I think, are the more unique complications associated with the bypass. They typically don't occur in the first week or two, so these are more likely to be long-term complications. 3 to 5% of patients after gastric bypass can experience an ulcer, and that tends to happen in that area where the small pouch is connected to small bowel. Mostly it's smokers that get it, but I also caution people who rely on NSAIDs, N-S-A-I-D apostrophe S, so-called anti-inflammatory medications like, for example, Advil, Aleve, Motrin, goodies or BC powders. Those types of medications, if taken frequently and at high doses, can certainly cause an ulcer. Why do you worry about an ulcer? It can hurt. It can cause nausea. It can also lead to you having a bleeding issue or, again, a perforation, which kind of acts like a leak, basically. So you definitely want to keep that in mind if you're going with a gastric bypass, and avoid that class of medication as much as possible, and ask for alternative pain control medications if you find yourself needing that. Last but not least, obstruction. With the sleeve, we didn't do anything to alter the small bowel. We didn't divide the small bowel. We didn't do that reorientation. And so a sleeve yes, when we say it has fewer complications, I think we can subtract these two complications, ulcers and obstructions, from a sleeve, because that we don't see them with those surgeries. But these are unique to a bypass. They still happen, but at a low rate. And an obstruction tends to happen at that point where we connected the small bowel to itself. So that lower connection point, it's about a 1 to 3% lifetime risk. And so you want to be aware of that when you're factoring your surgery decision making. Lastly here, it's really not a complication, it's a side effect. It's called dumping syndrome. It's due to an intolerance of a high carb-loaded or fat-loaded meal in that portion of the small bowel that's been connected to the pouch. Dumping syndrome, again, a side effect. What are the symptoms when you experience this? And this classic time when this happens is you've eaten a carb-loaded meal, not your dense proteins, and you guzzle down some liquids while you're eating. Well, you're just going to flush unprocessed, kind of dense carbs into your small bowel, which is not used to seeing those calories without, again, the mixed enzymes in the bile, which are acting on it to break it down. So this can trigger nausea, vomiting, diarrhea, abdominal pain, cramps, flushing, dizziness, lightheadedness, or high heart rate. I actually think this is kind of protective. It's in a weird way, it can help you achieve better results and maintain results, because once this happens one time, you're not gonna ever eat what you ate again that causes symptoms, or you're gonna make sure you stick with our recommended way of eating, like the dietitians will go over. So overall, I think this is a negative reinforcement that can keep you on track. I think it lends itself to why the bypass is, again, more durable for weight loss long term. So I tend to think of it, yes, you don't want to do it, but 99% of the time it's totally controllable and avoidable by doing the right thing. So if you're someone who knows, I have slight kind of binge eating or emotional eating habits, I know once the sleeve restriction's gone and my metabolism's back down, or I'm anticipating some stress, that I may default on my bad habits, I'm going to need something that's going to keep me in check. You may kind of subtly use that to help make the decision towards a gastric bypass for your surgery of choice. Malnutrition is a risk. In this case, I told you with the sleeve, it's still a small possibility it happens, but can be managed with 1 to 2 vitamins a day for the rest of your life. In this case, we're going to up that to 2 or 3 vitamins a day for the rest of your life, and relatively more vitamin level checks and follow-up. So, you may call that a little bit of a nuisance, but if you're trading off your insulin, your metformin, your hypertension medications for a couple of extra vitamins, I think that's a big win. All right, so that's it. We've just gone over the gastric bypass and how it works, and I hope you found that eye-opening and really helpful to see how we altered your anatomy to get the changes that we wanted. Could be beneficial to you, and I hope you found that you can better now decide between a bypass and a sleeve. Stay tuned, of course, for the following videos. I hope to cover the newest kit on the block, the SADI, S-A-D-I operation, as well as the classic duodenal switch, which is really our most effective weight loss surgery. And as always, you can follow us or subscribe to the channel here at Beltline Bariatric, and also look me up, Dr. D Surgery, if you want even more detailed and more comprehensive kind of slideshow formatted videos, which of course I give access to all my patients for. And also look up our other surgeon down in Noonan, Georgia, Dr. Roger Eduardo. You can find him at the Bariatric Surgeon on any social media platform. So stay tuned for more videos. Again, I hope you found this helpful, and stay safe out there. Until next time, thanks.